Yeah, thank you very much, Ray, for this kind introduction. It's a delight to be here in Boston, and thanks for Adam for helping organizing this meeting. And it's a pleasure for me to talk about expanding treatment criteria with nucleoside analogs, which we're trying to engage into anyway, but particularly for trials aiming at curative treatment. I would like to say some words to see how we should navigate. This is obviously all known to you. We have a rather complex start of treatment criteria. The EASL guidelines are a little bit more liberal than the American guidelines, but you have to start at a relatively high HBV DNA level to get treated, and definitely at a very high, even more so, ALT level of 2 times the upper limit of normal, which I consider as rather high. And I actually treat many patients outside of the treatment guidelines currently in the Netherlands. If we were to do that, this is obviously a huge step forward in the number of patients that we have to be treating. And the question is, should we treat all S-antigen positive patients or only the HBV DNA positive patients or HBV DNA above a certain level? We don't really know yet. But if we were to come to that scenario, the floodgates would really open and there's a ton of patients to be treated, which wouldn't be easy, but important. So no treatment criteria does not mean no risk. That's, I think, very certain from many studies. This is a study which was done, I think, from Singapore, where patients were not meeting the standard treatment criteria. So they were either immune tolerant, still immune active, but not matching the treatment criteria of the guidelines, or inactive. And as you can see here in this first slide, the 10-year cumulative incidence of HCC within that group, not matching the treatment criteria, was definitely higher as compared to patients who were inactive carriers. And also in multivariate analysis, this factor remained to be an important independent predictor of worse outcome. More so, if you give them antiviral therapy, and again, this is the same study group, a study published a few years later in hepatology, the indeterminate phase, so those outside of the treatment criteria, and if you treat them, they have a much better response, or at least less HCC over time than if you do not treat them. And again, also here in multivariate analysis, this was an important factor. So we all know that the guidelines that we have considering treatment are complex. The average hepatologist does understand it, I hope. The average gastroenterologist does not, and the general practitioners do not at all. So it's really, really complex, and we really have to simplify our treatment criteria. So there's still room for curative treatment, obviously. That's what we're here for today, because we know that if you become HBs antigen negative or undetectable, your outcome over time is better than if you're just HBV DNA undetectable. If you see the upper 2 lines, there's a clear difference there. And the question is to pre-treat, should we have treatment naive or should we have nucleoside analog treated patients in our trials? And most of the trials have patients that are on treatment for good reasons, but there's also reasons to say that we maybe should not treat everyone before we engage them into curative, like in investigative curative agents. So active disease might be, these patients might be immune primed. We've seen also with the studies, the REEF studies, that e-antigen positive patients who were very active sometimes did quite well. If there really is an immunological reaction which is effective, the S-antigen can drop down very quickly and these patients can become S-antigen negative. So these patients might be more immune primed. You're better able to evaluate the viral dynamics if you're not nuke pre-treated. These patients might be more likely to accept finite therapy. Better able to access independent contribution of each drug if you don't give nukes, and you do not need to stop nukes, because nukes are very easy to start but very difficult to stop, whatever scenario it is, whether it's in clinical practice but also when it is in the setting of clinical trials. On the other hand, the nuke-treated patients, they might have a partial immune restoration, which has been published about. It's by far not enough really to tip the balance towards immune control, but it's been reported. You definitely have a better protection against flares, which is a very important factor, I think. We've seen nasty flares happening, and you really don't want that if you're developing your drugs, unless they would be effective and not too strong. There's a potential additive effect. Reduced risk of drug emergent resistance, which we've seen with the CAMs, and many patients are in our hands with antiviral therapy. Some of them might be more difficulty to accept the treatment. It's unclear when to give the Nucs. Should you do it long-term pre-treatment so that patient is really solidly suppressed? Should you give a lead-in treatment? Should you give it simultaneously? Should you give an overlap treatment? We don't know, and it may depend on the type of target engagement that is being given. So here, just an overview, which you might have seen, and again, the vast majority of the studies do include a nucleoside analog. The question is, should we start nucleoside analogs to later withdraw it as a therapeutic intervention in curative trials? And I'm kind of skeptical on that. I think we should have to get an S loss on treatment and not off treatment, and we should be reluctant to use nucleoside analog withdrawal as a therapeutic intervention in itself in new combo trials. In my view, it's too risky. We've seen the cases in the REEF-2 studies. We've published on it as well. It's a very heterogeneous response. Many of the S losses occur only 2-3 years after the treatment has been stopped, which is really too long if you develop a drug. And the regulators will likely not accept it. So the nucleoside analog withdrawal is to be considered 6 to 12 months after sustained S loss, I would say, or a very low S level if it has been achieved with new compounds. So just to talk on the terminology and the patients that are falling outside the treatment criteria and how to move on with them. And I particularly want to focus on the immune tolerant patients, or HBs engine chronic infection patients, as we say, or the immune control patients that are both not in our treatment criteria. And then I'll have one slide on the gray zone, the indeterminate patients as well at the end. So if you look actually to start with the immune tolerant patients at the data, which is around, it's not very promising, but it's very tough to study this well. You need a very large 10,000 patient study with, 10, 20 years of follow-up and HCC as an endpoint, for instance, placebo control, to really get that done. We've never had the money in hepatology to do it. It's a very expensive study, so for that reason it is unfortunately never done, but we should have done it 10 years ago because we might have had the answer by then. This is a shorter study from Henry Chan, where patients were treated for 4 years with either tenofovir or Truvada, so tenofovir and tricitabine, and only part of the patients actually after 4 years of treatment reached the primary endpoint of an HBV DNA below 70. A little bit more in the combination group. Most of the patients that were HBV DNA positive had an extremely low level, but they were above the cutoff value. So that's not what we would want, preferably. And the secondary serological endpoints were actually quite disappointing, with only 5% of the patients becoming E antigen negative, and none of them S loss. This is another study, not randomized controlled, not a randomized controlled trial, but a matched cohort series where immune tolerant patients were compared to patients who were treated on immunoactive disease. So the treated patients had a better outcome towards 10-year HCC incidence, as well as to less death or liver transplantation. I would say the HBV DNA value of 20,000 is a bit low to really say that this is an immune tolerant group, but definitely here the treated patients who were immunoactive did do better than the immune tolerant patients, where a considerable amount of patients develop problems over time, and obviously sometimes they wake up and they become immunoactive, but if they're not well surveyed, not well monitored, these things might happen. Another important reason, I think, to consider treating immune tolerant patients is that particularly if your viral load is very high, you have more integration of HBV DNA. That's been shown now in several studies. This is one of the most elegant ones coming out of Taiwan by Holden Su, where he treated patients either with tenofovir or with placebo for 3 years, and he took a biopsy at the beginning and a biopsy at 3 years' time. And he was clearly able to show that there was a reduced expression of viral integrations and dysregulated genes, which we all consider as really a prelude or like a pre-step towards oncogenesis and HCC over time. Oh, I should go back. So particularly if you look here, let me see if the pointer works. Yeah. Here you see the difference between the two groups, the tenofovir and the placebo group. This is year 3, and you can see in green here in this line, the HBV DNA stays low and is related to less integration. So that is an important factor to take into consideration. So treat patients in the immune-tolerant phase, yes or no? What are the pros and the cons? The pros are, I think, very important. You reduce HBV integration, as I've said. IT patients will develop active disease anyway overall. So some people say, particularly out of the infectious disease community, why wait until the house is on fire? It's better to prevent the fire from happening, really. So you could like short circuit through treatment early on, which is now safe, cheap, and without resistance. You will reduce the rate of transmission. It will be much more simple, which is important, and you will reduce stigma. The cons is that we know that there's incomplete viral suppression, that there's limited E and S loss with the short-term follow-up that we've seen, that there is minimal liver disease and limited progression of disease in many of these patients. And we have to be careful to put all of our young patients on long-term treatment. They might stop treatment all of a sudden, which can be dangerous. So we have to be very careful there. And I think likely the patients who are transitioning a little bit towards immunoactive disease over time, so when they become a little bit older in their late 20s or 30s, their ALT is increasing a little bit, their HBV DNA is decreasing a little bit, and you feel that they are moving into an immunoactive phase. Definitely there they should be treated, but even I think earlier on, there's lots to say for treating immune-tolerant patients. What about the inactive carriers? I think there it's less certain that we should treat still. These patients might be more easy to treat than we think. We don't typically do that. They have low ALTs, low HBV DNAs, their prognosis is quite good, and we're quite reluctant to treat them. But if you look at this older study where these patients were treated with peg interferon and entecavir, it added up to 45% HBS loss, mind you. So that's pretty high. And if we it's difficult to assess again the endpoints because these people have a good prognosis, as I've just said. But they're low-hanging fruits to get them into S antigen loss. So we really might consider treating them as well for other reasons. Maybe they'll have a better prognosis, but also regarding stigma, etc. So why treat immune control patients? You could say reduce the risk of HCC by suppressing virus to the absolute minimum. The only good virus is an undetectable or even better an absent virus. That's not very scientific, but it might be true. It appears effective, but with limited evidence, and the challenge is indeed to demonstrate improved prognosis for these patients. And the other point is that patients with immune control might not stay in immune control. We've done studies over time where these patients move into the undetermined phenotype or even in an immunoactive phenotype in 15 to 20% of the patients. So they do not always stay in the immune control phase. And then lead-in treatment with nucleoside analogs in this population might also be important because they have a high response to the new curative regimens. And if we enrich our trials for low S antigen levels, these are patients to take into account for nucleoside analog pretreatment. Just one slide on the gray zone patients, and those are mainly patients with a very low viral load, below 2,000, but elevated ALT. where you first of all should obviously exclude other liver diseases, particularly NASH. And the second big group is those with moderately high viral load, so 2,000 to 5-6 logs, but normal ALT. And also here, I mean, the evidence is limited, but the studies that have been done clearly show an effective treatment. This is the study from Holland Sue again, which I referred to earlier. Here you see the outcome of fibrosis over time in the 3-year time that these patients were either treated with tenofovir or placebo, and definitely there's a much bigger regression of fibrosis over time in the treatment group. So this is my last slide. Should we treat everyone with nucleoside analog? I'm not sure, but there is an increasing push also from low and middle income countries to treat all, I would say at least HBV DNA positive patients, and maybe even all HBs antigen positive patients. I think the last one is a bit too ambitious maybe, but it would simplify that we can test and treat, which is important for patient care. Frequent follow-up and diagnostics might be more costly, and the rationale is thus that with generic drugs, likely it's more cost-effective to treat these patients than to have them come into clinic, do HBV DNA testing, which currently is much more expensive, particularly in the low-income countries where treatment is very cheap. The nukes are safe. Resistance is rarely a problem, or actually not a problem if you pick up the right drugs. The benefits are hard to see in a cohort, but may be apparent at the population level. So we definitely should do studies at the population level, big number studies to see what's going on. It will simplify our treatment guidelines. It will reduce transmission. It will destigmatize our patients. And treatment might not be lifelong if we have good curative options coming along. The risk is adherence, stopping therapy, and the toxicity of a novel therapy, which might be unwanted if it has side effects in patients without a current formal treatment indication. So we really would have to adapt our guidelines towards that. Thank you very much for your attention.